Now, moving on to our first section, that is the carpometacarpal dislocation. As you know, then in this we'll be discussing mainly the carpometacarpal dislocation of the thumb, which is the most common dislocation. We'll be briefly discussing the chronic instability of the thumb, and then in the lastly we'll be discussing the fourth or fifth finger, which is although rarely involved but can get involved, especially with the fractures which are involving a boxing or punch fractures with the thumb hitting a wall or a hard surface. Especially we'll be discussing the finger carpometacarpal joint dislocation. Now if you see this anatomy over here, these are the metacarpals. These are 1, 2, 3, 4 and 5. Then there's the proximal interphalangeal joint, the middle phalanx, and then comes the distal phalanx. In between them we have a proximal interphalangeal joint between the proximal and middle one. Then between the middle phalanx and the distal phalanx we have the distal interphalangeal joint. And these are the carpometacarpal joints in which this joint can get injured or fractured, especially in the case of carpometacarpal fracture joint dislocations. Now, most commonly what involves it involves the thumb area. And why it is thumb? Because thumb is actually the most mobile part of the hand, and mainly in the pincer grip and functions mostly that the thumb is actually rotating around the fingers. So thumb is the most commonly involved in the case of injury of the carpometacarpal fracture dislocations. Clinically injured then resembles usually a Bennett fracture dislocation. And it's important when it is associated with fracture, then it may resemble a Bennett fracture dislocation because it is usually intra-articular oblique fractures as well, sometimes present as well. We need to evaluate the X-ray very carefully because sometimes it's only the X-ray has actually a Bennett fracture, and because there is not oblique X-rays are not taken, therefore you confuse it with the fracture dislocation, and sometimes it's the fracture dislocation which is present, and as the proper views are not taken, usually this results in a Bennett fracture. It's taken as a Bennett fracture. If you see this over here, this side, this is the area. Now this is from where the metacarpal is starting. If you can appreciate overlap at this point, although there is no fracture, but this overlap is normally not present. This means either the phalanx or this metacarpal has either gone volarly or dorsally displaced, leading to overlap. And usually the X-ray reveal proximal subluxation and dislocation of the first metacarpal bone without a fracture. And most commonly it is the proximal subluxation leading to this kind of overlap over here. Usually, as the rule with every dislocation, if it is present without fracture, the first and foremost technique is to reduce by close reduction means. How do we reduce it? We reduce it by traction and hyperpronation. That is obviously done under controlled analgesia. Usually the patient is either sedated with or the patient is given at least enough wrist blocks so that the patient is pain free. And these tractions and hyperpronation of the thumb is actually done to reduce back the subluxed or dislocated metacarpal of the first metacarpal of the thumb. Reduction held is then it depends. Usually if it's a massive injury, it's associated with ligamentous injuries as well. So sometimes the reduction it can be easily done in closely, but then it remains unstable, and the thumb is actually prone to redislocation. So if it's unstable, then you just apply a K-wire driven through the metacarpals into the carpus. That is, you join these two areas after the reduction so that the metacarpals and carpals anatomy is aligned, and they stay aligned for a few weeks. Wire is removed at 5 weeks. By the time the capsule has actually healed somewhat, and then there is actually increased instability, protective splint then can be worn for 8 weeks. The important point is then you have to at least the rehab continues for 6 to 8 weeks at max. It may continue up to 12 weeks as well. Now, if this is associated with chronic instability at times as well. Why? Because acute injury happened, there was no fracture, the only dislocation was there. Dislocation was reduced despite the K-wiring and splint is done. Sometimes the ligaments do not heal properly. This leads to kind of a carpometacarpal chronic instability of the first carpometacarpal joint. So that is important. If it's treated, it has to be treated as early as possible. Otherwise, once the degenerative arthritis is going to be developed, then you probably will not be left. The only option would be the arthrodesis. Otherwise, pain will not go away, especially if it's associated with arthritis. And how do we do that? Because we know that ligamentous reconstruction is sometimes required because the ligaments have not healed properly and has not actually given enough stability and to the carpometacarpal joint. So what we do is we use a flexor carpi radialis tendon to actually, in a surgical fashion, we provide stability to the carpometacarpal joint. And as you know, there are actually as high as 16 ligaments which are required to provide stability. But there are 4 main constraints of the carpometacarpal joint. One is anterior oblique ligament, then it's posterior oblique, then there's a transverse ligament as well, and then there are other ligaments as well associated with it. So it's what's important is that radial oblique ligament and all these has to be reconstructed by use of flexor carpi radialis tendon. To reconstruct the ruptured and incompetent palmar ligament of the carpometacarpal joint, because these ligaments are primary stable restraint to the movements of the carpometacarpal joint. Otherwise, this reconstruction, if not done, would lead to increased instability. Therefore, that has to be reconstructed by use of flexor carpi radialis tendon. Now coming to the rather rare dislocations, but yes, they can happen. That is the finger carpometacarpal joints. It usually helps in punching or falling on the fist. Usually the 5th and 4th metacarpal joints are involved. Most commonly it's always the little finger, the 5th joint. Rarely all carpometacarpal joints are damaged. Death can occur, but it's very rare, usually associated with the high-energy trauma and often associated with a fragment of bone from the hamate. When there's a fall on this kind of punch fracture or there's a fall on outstretched hand, this can lead to hook of hamate fracture along with associated fracture dislocation. And diagnosis is usually very clear. There's a history of trauma. The hand has actually swollen up quite rapidly, and mainly the 4th and 5th finger are more swollen. There is increased tenderness, pain over that area, especially over the 4th and 5th carpometacarpal joint. And true lateral X-rays would reveal the classical dislocation pattern. Treatment is actually, as with any dislocation, if it's not associated with fractures, is first initially close reduction, and then if it's stable, we can only go for the splint putty taping. But if it looks unstable, we can apply K-wire as well. Now, if there is a late presentation, usually if it's missed injury or if it was a sublux injury and patient who could not be present time, or what it was associated with polytrauma, the patient had a head injury, patient was in a coma, and probably when the patient came out of the coma, told probably yes, she's having a pain over the finger area as well. That is when the late presentation comes, then usually is always treated by joint fusion, that is arthrodesis. Why? Because arthritis has set in and probably the pain will not go away with simple ligamentous reconstruction. If just 5th carpometacarpal joint involves, need operation to fuse the base of 4th to 5th metacarpal can be done, or the simple is to excise the articular surface of the 5th metacarpal. Why? Because this is where the real pain is going to be. We excise the articular surface and fuse them together with carpometacarpal joint, leading to carpometacarpal arthrodesis. In this section, we have briefly gone through relatively rare injuries called as carpometacarpal joint dislocation. Most commonly, they're involved with the thumb, and most commonly it's proximally subluxed. Usually associated with hyperextension injury of the thumb and leading to sometimes associated with fractures, sometimes not associated with fractures. The best and foremost treatment of any fracture dislocation is, or simple dislocation, is simply close reduction and application of K-wire for the and from metacarpal towards the carpal bone, so that the carpometacarpal joint dislocation is reduced and remains stable. Later on, it can be splinted, and for 6 to 8 weeks after that, we can remove the splint and start the rehab and range of motion exercises. Thank you very much. Keep watching sqadia.com.